The issue with prostate cancer, the issues are pretty straight. One, it's the number one cancer in men, and it's the number two cause of death, and that hasn't gone away. And we've tried to deal with that issue for decades. And not so long ago, before we had PSA and widespread screening, most cases of prostate cancer were diagnosed in a metastatic stage. And so, through efforts of a number of organizations, we started to go out and seek prostate cancer and find it early. And some people call that screening. I call it early detection. And we started national campaigns. And one of the things we did in 1989 was start Prostate Cancer Awareness Week. And the idea was to find prostate cancer early. And at that time, several years before, there was efforts to find breast cancer early and breast cancer screening. And through a number of trials, they supposedly showed that it was beneficial. We didn't have that with prostate cancer, so we started this. We tried to get a national spokesperson for prostate cancer. At that time, there was a lot of press about Betty Ford and Happy Rockefeller and all these people, women that had breast cancer. We couldn't find anybody to talk about prostate cancer. Prostate men were sort of, that had it, were relatively quiet and didn't want to talk about it. So we got a spokesperson, a guy named Rocky Blyer, whose grandfather had prostate cancer. And most people don't know who he is, but he was a running back for Pittsburgh, who was sort of a hero, Vietnam War hero. And we started. And that was 1989. And then PSA came along, and the revolution occurred. In PSA, we were able to find prostate cancer. So we saw the number of new cases of prostate cancer increase substantially in men who came in for screening. And we thought we were seeing, we were sticking needles in prostates and so forth. And then what became apparent is that maybe we were overdiagnosing the number of patients that needed to be diagnosed, or overdiagnosing prostate cancer and overtreating. And that lasted for over a decade. But organizations such as the U.S. Services Preventive Task Force looked at that, and they gave it an indeterminate for a while. And then they looked at it and said, we don't think you should screen men over the age of 73. And then the major blow came 3 years ago when they gave screening AD, which means don't do it, basically, or if you do, go out of your way with informed decision. So that was actually, I think, a good thing to happen. Most urologists don't feel that way, but a correction was needed. We were overdiagnosing and overtreating people. And I think that a lot of us recognize this, and had we have some of the markers that we're going to talk about here in the next couple of minutes, we wouldn't have had that problem we had with overdiagnosis and overtreatment. So the focus today is to find the cancers that are threatening. And we pretty much know what they are. They're not low-grade, what we call Gleason 6 cancers. And as a matter of fact, these are being reclassified as Group 1 rather than 6. Because when a man hears a 6, I got a 6 out of a 10, most of us would say, well, that's over halfway. That's not good. But we know that in studies that of men that have had radical prostatectomies with Gleason 6s, that they don't die of prostate cancer. That's up to like 19,000 men. But the issue is they had Gleason 6s, they had it removed, and they didn't have 7s, or pattern 4. And so that tells you maybe we didn't need to treat all those guys. And that Gleason 6 maybe is a toothless lion, which is the sort of the title of this talk. We want to eliminate those. We talk about active surveillance. I think we want to eliminate active surveillance. We don't want to find those. We want to focus on men who have significant cancers, and that's what I'm going to talk about. But the other thing we have to deal with is the damage that has been done with this overdiagnosis and overtreatment, and the feeling of the family practice doctors, internal medicine, about the whole concept of screening, and that's what I want to talk about. So the current clinical needs I see in prostate cancer are the primary care physicians need a simple message. The second thing is, and I'll tell you what I think that is. The second thing is we need to identify patients with clinically significant prostate cancers early. And the best I can tell is that these are men who harbor more aggressive Gleason scores, and we usually say that's a pattern 4. So a 4-3-7, or a 4-5-9, or a pair of 4s, 8. We also, this was in the forefront of U.S. Services Preventive Task Force when they looked at all this. We do 1.3 million biopsies in the United States every year. We diagnose a couple 100,000 people. That means we do a lot of unnecessary biopsies. We need to hone in and have a higher positive biopsy rate of significant cancers. And the other thing is we still are going to find some Gleason 6s or other low-grade cancers or 3-4-7s. And the issue is we need to risk stratification because all those people don't need to be treated. So that's the way forward. Those are the challenges. We need to deal with all of this as we talk to men. So one of the things that we have in oncology and medicine is our biomarkers. And when I talk about biomarkers in prostate, I call them PCMs, prostate cancer markers. And they can come from 3 sources. The easiest source is urine and blood. A more difficult source to deal with is tissue. And what are biomarkers? What are PCMs? Those are molecules that can be found in these 3 areas, blood, tissue, and urine, that is a sign of an abnormal or normal process. So when we think of biomarkers in prostate cancer, the first comes to my mind is a blood test called PSA. Okay? That is a great, and PSA actually is one of the most important markers and biomarkers in oncology. What other marker can give you a reading on recurrence of disease, and you can follow somebody? You don't have that for breast cancer. You don't have it for melanoma. You don't have it for colon cancer. You have CEA and all these other things. For testis cancer, maybe close. We have AFP and HCG. But PSA, if you had a radical prostatectomy or radiation, basically you should have an undetectable PSA. The people that really do well with radiation, and we can argue that, are people that get really low, undetectable, stable PSAs. So PSA is good. The issue is, as has been alluded to already, PSA stands for prostate-specific antigen, not prostate cancer-specific antigen all the time, and there's other things that give you a issue. So we've got to move forward with family practice doctors and helping them with a simple message that defines who's at risk of having significant prostate cancers. And we got to stop these unnecessary second biopsies and so forth. And there's all these terms being floated around right now about integrated precision medicine, personalized diagnosis, and therapy. Well, we sort of do that with prostate cancer in a way. There are 3 risk factors: that their age, right, family history, and African American race. That's sort of personalized medicine, that we're going after, specific targets. But we can get better. We can get better on focusing, so like one dictum doesn't apply to the whole population. So we know that when I ask a group of urologists, what percent of PSAs are ordered by urologists? And they go, wow, 50, 60%. And we know, as Dr. Rosenberg has pointed out, is that urologists only order 6.1% of the PSAs in the United States. So now, if you're going to focus on where the issues are, you go to the source. And the source is that over 90% of these tests, at least in the past, are ordered by family practice internal medicine doctors. So that's where you got to start. And here's the problem. The problem is that they're confused, and that's the urologist's fault. We have PSA cutoffs of 1.5, 2.5, and 4. We have PSA velocity. We have PSA density. We have age-specific PSA. We have percent-free PSA. We have complex PSA. And by the way, we have 5 PCA3, select 4K score, and they go, help. Urologists don't even understand this. How are we going to understand all this controversy? They need a simple message. And so what I did, and I knew this from the infamous PLCO trial. We were one of the 10 sites in the United States. And we also have data from our prostate cancer screening that started in 1989, that there is a cutoff of a PSA below which you have relatively little risk of having anything bad happen in the next 5 to 10 years. And so I did report this at the plenary session of ASCO a number of years from the PLCO trial, that if your PSA was less than 1 within the next 5 to 10 years, and it's actually closer to 10 years, your relative risk of having an elevated PSA that was significant for cancer, and at that point we said above 2.5, was less than 1%. So that's personalized medicine. If your PSA was less than 1, you probably didn't need to be screened for a while. So what we did is we had to have a contemporary thing to give us the relative risk of cancer and so forth. So I went to the Henry Ford database, which I've worked with before, and it's a very robust database with follow-up with 30% African Americans in that database. And what I said is, based on what I know, let's look at the relative risk of prostate cancer in men who have a PSA of 1 to 4. Because I knew less than 1 was not going to be anything from our hundreds of thousands we had from our screenings. And I also knew above 4, most people, the risk is pretty steady of having prostate cancer from like 20 to 30% up to 10. And after it gets to 10, it goes up even higher. So what about this danger zone of 1.5 to 4? So that we started out with 350,000 in that cohort to look at it, and distilled it down to 21,000, where we had a first PSA, we had follow-up of 5 years, and they weren't on anything that was going to alter the PSA, like a 5-alpha reductase inhibitor. And so what we found out was the mean age was 55, 29% African Americans. And what we showed very nicely was if your PSA was less than 1.5, your relative risk of being diagnosed with prostate cancer in the next 5 years was 0.51%. Most of those, by the way, were low-grade cancers. However, if your PSA was 1.5 to 4, and we call that a danger zone, your risk of being diagnosed with prostate cancer was 15 to 19-fold higher if you were Caucasian or African American. So the relative risk was about 8% if you were Caucasian and over 10% if you were African American. So here is personalized medicine. This is identifying high-risk patients. Now, the issue is most of the time that PSA elevation in that area is not just prostate cancer, but it's BPH. And we showed and published, and Klaus Rurburn started this, and we followed this up with the MTOPS trial, that if you, and on our average age in our study here at Henry Ford was 55, so if you were 55 and had a PSA of 1.5, you had a 30-gram prostate, and then what happens over a period of 15 years, that prostate size doubles because you're on the slippery slope when that happens. At PSA 1.5. So the PSA 1.5 is a marker for BPH also in progression. So that's important. And when you have larger prostates, in general, you're going to have more urinary symptoms. All right, so this was just published in Renal and Urology News over a year, not quite a year ago. and showed that as the size of your prostate increases in 10 ml increments, or 10 grams, your risk of urinary symptoms go up 12%. We knew this a long time ago. This is not new. And Klaus Werburn, and we published that in the MTOPS trial. So the question is, what percent of people have a PSA above 1.5? Because the question is, if you're going to use that PSA at 1.5, what it's going to do is, are you going to open the floodgates to a lot of people that would need to be evaluated and biopsied? And we knew this, actually, these numbers from our screening from Prostate Cancer Awareness Week, basically that about 30% of men will fall into that bucket of having a PSA of 1.5, whereas 70% won't. And Matt Rosenberg very nicely looked at the data from bioreference labs and 217,000, and I recently updated the 450,000 men, that about, in fact, when you look at it, 73% of men, and this is from Matt's data, have a PSA of less than 1.5 that don't require a discussion. Okay? And why are we saying that? It's because family practice people operate like this. When you come in to see them, they don't get informed decision to check your blood pressure, to check your weight, to take blood from you, or anything else. They don't tell you, if I draw cholesterol on you, I might have to put you on statins and you might have rhabdomyolysis or liver problems and die. They don't tell you that. They talk to you after the diagnosis is made. They don't tell you, if you have hypertension, that if I treat you, you might go out, pass out, wreck your car, get up in the middle of the night, faint, break your hip and die. They don't tell you all that stuff when they check your blood pressure. They talk to you about afterwards. They don't, when they check the other thing is, there are levels of tests that you do. You might start out with a screening test like fasting blood sugar and then go to the next level. So my point is, and Dr. Rosenberg's and others, is that you treat PSA like every routine thing that they do. The informed decision comes after the abnormality, so you're not wasting your time talking to 73% of men that don't need it. And so the way forward is that this is treated like vital signs and many other tests. Informed decision occurs when they are abnormal. Why not PSA? And that sort of gray zone, danger zone is 1.5. Now, here's the issue. A PSA 1.5 to 4 is not associated with prostate cancer as much as it is with BPH. So everybody that has an elevated PSA 1.5 to 4 does not need a prostate biopsy. They need to be evaluated, like AUA symptom scores. I think family practice doctors should use AUA symptom scores. They're very simple. It saves you time. It's reproducible to see what's going on with it. And I know that there are a lot of forms that patients have to fill out, but it saves you questions, it's documentable, it's reproducible, and it gives you an idea. So a guy comes in as PSA is 1.9, and he's got an AUA symptom score of 19. You might think about, okay, and he's probably got an enlarged prostate. He could have prostate cancer. You can't say he doesn't, but maybe what you should do is evaluate and treat him for BPH. Or we'll talk about, in that group that's suspicious, going on to another test. It's your A1C hemoglobin. It's your new biomarkers and things like that. So we published a paper on this in the PSA 1.5 cutoff for primary care. It just came out this month in Urology. And we've got leaders from around the country here, and it wasn't easy to get these people to have a consensus. So the way forward is that the most common surrogate for this elevated PSA is BPH. Prostate cancer is there. Long-term risk of prostate cancer is there also. This is Hans Lilia's work looking at an initial PSA. We didn't get it into the mud of, when do you stop screening, when do you start screening, things like that. You're never going to get a consensus on that. People say you should have your first PSA at 45. I agree. If your PSA at 45 is 1.2, you probably got a problem. Whereas if it's 0.3, you probably don't. I don't think there should be a cutoff by age of 73 or 70, because we see a lot of 80-year-old men right now that are going to be living to their mid-90s. And if they have a high-grade prostate cancer, it can kill them. So again, you have to be focused. Urologists need to be good citizens now if this is turned around. So everybody that comes with a PSA of 1.5 does not need a biopsy. They need evaluation. Or the family practice doctor can evaluate them. Can these markers help? So the point is here is that PSA is out there and it's important and people are getting it. So here's my view of life here. Family practice doctor, patient comes in to see the family practice doctor. PSA is a routine lab test. In somebody that has a 10-year life expectancy, that's your decision what you do when you stop. If it's less than 1.5, you get a green light and you come back in 5 years, and maybe we'll have some data very shortly that can be extended to 10 years. If it's greater than 1.5, you get a yellow caution light. Doesn't mean you don't get a red light, you get a caution light, something's wrong. And that's where maybe the family practice doctor can take it from here and do the next level of test, evaluate it, or refer to a urologist. And that's where the evaluation for BPH and other things occur, and the thing you do is do some of these new tests, the new biomarkers. What do? They help us determine who has a higher grade pattern 4 cancer present. So, Gleason 7s and above. That's what it's all about. To find those and not find the 6s. If you do one of these tests, and I'll talk about them in a minute, and they're low risk, you come back into the normal screening mechanism. If they're high risk, you do a biopsy. And if the test is negative, the biopsy is negative, there are biomarkers, we're going to talk about this later on, to help us determine who to re-biopsy. And one of them is called confirmed MDX. If that test does not show a risk for prostate cancer, you're back into the screening population. If it does show, so this is a person's had a biopsy, the test shows that there's still a risk of prostate cancer, then I think this is where MRIs come in, multiparametric MRIs for targeted biopsies. If the biopsy, the initial trust biopsy, has pattern 437 and above, and the patient's healthy, they should get a local treatment. Radiation, surgery. We could spend an hour talking about the pros and cons of each. In general, the survival rates for both are similar. The side effects are not similar all the time, and long-term outcomes, maybe beyond 15 years, aren't. So consider treatment. Gleason 3, 4s, or 6s. People argue about the 3, 4s. That's where we need to make sure we're not missing anything, and where genomic markers come in, such as Oncotype DX and Prolaris, that look at the genetic profile that give us a new level there. And if those markers are high risk, consider treatment. If they're low risk, this is where active surveillance goes. So we know that there are some guidelines. I'm just going to talk a minute or two about treatment because we're talking about toothless lions and who gets radical prostatectomy and radiation, and that's where we really went sort of away from where we should have been by overdiagnosis and overtreating them. So, but we have guidelines. The AUA says a patient with clinically, and American Urological Association, clinically localized prostate cancer should be informed about the commonly accepted initial interventions, including at a minimum active surveillance, radiotherapy, and radical prostatectomy. A discussion of the estimates for the benefits and harms should be offered to each patient. And this is not something that you just gloss over. It takes time to talk to the patients, and this is where multidisciplinary treatment occurs. And then we see that when they talk, sort of, it's some people are balanced. We have people go to the radiation oncologist, and they walk away with is that people leak all the time. They all have erectile dysfunction, and they recur. We have patients that go to see the urologist, and we portray the patient as you're going to have side effects from radiation. You're going to have rectal irritation, burning, things like that. erectile dysfunction. We know that a lot of these things, have to do with the institution, with the treatment, with the expertise, and various other things like that. But all of these treatments have side effects, and I tell every man that when they cross this barrier about being diagnosed with prostate cancer, that no treatment's going to make you a better man than you are right now. They all have side effects, and if somebody tells you they're not going to have the side effects, walk away. Because even in the best of hands, you have side effects. And so, things are often not what they appear to be. And there's a lot of stuff about robotic surgery. That it is, you're going to be a better man than you are right now. And we see that. And that sort of got knocked with some of the stuff in lawsuits filed on the internet about that very thing. Okay, so what we have is PSA doesn't tell you what disease to treat. It sort of helps you, make that and then look at all of the different navigations from, observation, treat, patients that fail, adjuvant therapy, a whole bunch of things like that. But PSA is good at defining failure early. So, we can sort of say this, that radical prostatectomy is the optimal treatment for clinically localized prostate cancer, particularly even at high risk. And, urologists are making up these guidelines or other, but there are actually some data that reflect about the response to higher grade cancers and long-term outcomes and risk and benefits. So, but I think they need a balanced discussion from radiation oncologists, particularly when we're talking about higher grade cancers. There are a lot of data about androgen deprivation and radiation therapy together. We hear a lot of stuff about robotic prostatectomy. Outcomes appear to be better, but they're not better. They're similar to open prostatectomies in people that do a lot of them. It's just the learning curve is a little different. That train has left the station. We're tired of arguing about it, the benefits. It's been shown study after study. Again, it's the person doing it. It's not a robot. Just because you have a race car doesn't make you a race car driver, and things like that. Extended node dissections in high-risk patients, and that are probably recommended. We have all sorts of new methods right now. We have clinical trials ongoing. I think that in the future, we're not going to be seeing as much radiation radical prostatectomy because we're going to find other ways to ablate the prostate, targeted therapy, integrating the prostate, focused therapy. You don't need your prostate. So if you have an immunological way to attack acid phosphatase, PSMA, or some other antigens in your prostate, you can get rid of it. And that's happening right now. There are companies that are doing it. It's on the forefront. So, it's sort of, we have to consider that. And we have to consider a molecular risk stratification to help us with that. So, this could, in the future, I think we're going to see this whole thing turned sort of upside down.